My mentor, Dr. Nilen Shah, who's a legend, so it's going to be a difficult task for me. Please help me and support me. Age. When did age actually become an indication for surgery? I mean, there is a chronological age as well as a physiological age. This is Jaya Bachchan, who's in her 70s. And this is Rekha, who's also in 70s. So if you take age into consideration for deciding what surgery you want, it'll get very confusing. There are strict criteria for partial knee replacement. Anteromedial bone-on-bone osteoarthritis, pristine lateral compartment, varus of less than 15 degrees, which should be correctable, intact ligaments, and flexion deformity of less than 15 degrees. There is no way age or BMI is mentioned in indications for fixed or mobile bearing. So let's not consider age. But since this debate is about the age, I'm going to cover these points in the debate. The scientific evidence that age is just a number, practicality, scientific evidence showing long-term survivorship of UKR, and common sense, which most of orthopedic surgeons have. So let's go to the first part. This meta-analysis of 6,130 UKR published in KSSTA not only shows that young age is not a contraindication, it also shows that UKR has excellent functional outcome in all age groups. This is the next paper. The study published in KSSR in 2018 by a non-designer surgeon shows that long-term clinical results of UKR were satisfactory in patients under 60 years of age. This is another paper. The study divided 1,000 unicompartmental knees and 2,252 total knee replacement in 8 stratified groups of less than 60, 60 to 75, and more than 75. And it concluded that UKR provided excellent long-term functional outcome in all age groups. Now let's come to practicality. I'm going to just discuss 3 cases and then you decide for yourself. This is a standard medial compartmental osteoarthritis knee in a 59-year-old male. Look at this intraoperative picture. This is the medial compartment and this is the pristine lateral compartment. I mean, it would be criminal to go ahead and offer a total knee replacement for this patient. This is what we did. A cemented mobile bearing Oxford unicompartmental knee replacement. He came to me for suture removal. This is the function of the patient on 15 days after suture removal. He's an active person, works in the in the cargo ships, and this is all what he can do at 15 days. I doubt a total knee replacement patient would ever be able to do that at 15 days. This is the 55. Now we are talking about obese, so high BMI. Another contraindication or a myth, as you can call it. Bone-on-bone osteoarthritis, obese patient, high BMI. This is the X-ray. This is what we did. This is the evening of the surgery, patient walking. And after walking, she's actually dancing and sent me that video in the night. And this is 4 years post-surgery. The same patient walking comfortably. So the criteria is never age or BMI. The criteria is bone-on-bone osteoarthritis, correctable varus, and pristine lateral compartment. This is a 53-year-old gross varus. This is the last case, gross varus deformity. But it is correctable, as you can see. This is the intraoperative pictures. Completely shattered medial compartment, completely normal, pristine lateral compartment. This is what we did, a bilateral one-stage partial knee replacement. And this is the function of the patient 2 years after surgery. So let's come to evidence of long-term survivorship. It is a known fact that it is published in JBJS in 2016, showing that revision rate decreases with increase in caseload. So if a surgeon is operating more than 30 unicompartmental knee replacement surgeries, he has a lower complication and lower revision rate as compared to somebody who's doing less than 30. So high volume centers have lower revision, lower complications of unicompartmental knee. This study shows, and it was published in 2025, 10-year follow-up of patients operated at age of 60, shows that even if the radiological picture shows progression of lateral compartment osteoarthritis, symptomatically and clinically, the patient has excellent outcomes at 10 years. This female was operated by a well-done TKR. She was operated at 55. by a senior experienced surgeon, a good TKR done. But at 10 years, she came to me with this X-ray loosening. Just give me 2 more minutes. Sorry, 1 more minute. Loosening and severe synovitis. At 65, I had to go ahead, build up the tibial defect and do a constrained implant. It was not a very good feeling to do this at a 65 years of age. So that brings me to the next paper. If we do a 55-year, if a patient of 55 years, you do a UKR and it fails at 10 years, we can go ahead and do a primary TKR, which gives excellent long-term results for a primary TKR. But if the same patient operated at 55 for a total knee and fails at 10 years, you're going to do a revision TKR, which we don't know what the survivorship of that implant is going to be like. So registry data is very, very biased. I heard that in the earlier talk. For unhappy UKR patients with a picture-perfect X-ray, most of the surgeons will go ahead and go down and do a revision surgery. Just imagine if that patient had a total knee replacement but is unhappy with a picture-perfect X-ray. How many of us are actually going to go down and do a revision surgery? So UKR-to-TKR count is counted as a full revision, but a poly exchange is not counted. And the registry is dominated by young surgeons with low volume, so it is completely skewed. And logic, if you buy a brand new car, a young car, and if one tire is punctured, are you going to change all the 4? Then why would we want to do it for the knee if only one compartment is destroyed?
So I request you to please present the conclusions for the sake of time.
Just to the chairman and the moderators, I'm competing with Dr. Nilen Shah. He's a lion, I'm a mouse. I need 1 more minute, okay? This is our study published in 2025 showing 96.85 midterm survivorship at midterm. And this is an Indian scenario. Thank you for your attention.